Hi, this is Andrea Kane, and I'm here with you for HIT 210. We are now on week 8, and one of the topics that I was hoping to cover this week is upcoding and downcoding. Something that you need to be very aware of when you are doing ICD-10-CM diagnosis coding. So let's take a look at this a little bit further, all right? What is upcoding? A definition for upcoding is when a healthcare provider submits codes for more serious and more expensive diagnoses or procedures than the provider actually diagnosed or performed. When providers upcode medical bills for Medicare and Medicaid patients, they cheat those healthcare programs of needed funds. So that's why we need to be aware of it. And yes, there can be upcoding with procedure codes, and we'll talk about that when we get into CPT 4 in week 10. But we're here really to talk about diagnosis coding right now with upcoding. So what are some examples of upcoding? Well, I've got 3 of them for you here. The first one is a company called CareAll Management LLC. It's a Tennessee home health provider. They ended up paying $25 million to the U.S. and the state of Tennessee to settle allegations that they upcoded home health billings to Medicare and Medicaid. According to the complaint, CareAll exaggerated the severity of its patients' conditions in order both to increase billings and to bill for medically unnecessary services. $25 million is an awful lot of money. Second example is Endogastric Solutions out of Washington. They are a medical device manufacturer, and they returned $5.25 million to the federal government because of upcoding allegations. They have a device that can be implanted through 2 procedures. One is more invasive and expensive than the other. When promoting its device to providers who would be inserting this device, Endogastric advised them to bill for the more expensive procedure, causing federal health care programs to pay more than needed. So obviously, if they don't need to do the more invasive or expensive, probably open procedure where they actually open someone up versus doing it laparoscopically, and going through that aspect, which is less invasive and less expensive, as you can imagine, it would be better for patients to have the less invasive and less expensive procedure if they can do that. Whereas the more invasive, more expensive procedure really should be saved for patients that need that. So this was definitely considered upcoding and fraud. NextCare Inc. This is an Arizona urgent care provider. They paid $10 million to the federal government in several states, settling allegations that its employees inflated billings, and they do that through coding, for a variety of urgent care procedures. The complaint also alleged that NextCare performed unnecessary medical procedures such as redundant allergy testing. So you can see, based on a lot of the billing comes off the coding. So if the coding isn't accurate, if it's coded beyond what's in the record or beyond what really is going on with the patient, they're going to get more money back when you bill it, and it's going to reflect a higher severity, but that's really a form of fraud because it's not accurate. It's not necessary. All right, now let's flip the opposite side. What is downcoding? Downcoding refers to coding at a level less than the service or than the level or service. Sorry about that. Let me start again. Downcoding refers to coding at a lower level than the level or service supported by the medical documentation or medical necessity. This means that it's you're undercoding. You probably are missing documentation and not doing a coding query. An example of this might be that you could figure out whether the patient's COPD is chronic or for instance, this congestive heart failure, whether it's left-sided or right-sided, those types of things. You can find that information out to make your coding more specific, to better reflect what's really going on with the patient. But some healthcare organizations kind of frown on that, and they just want you to code what the provider documented and not question the provider. And it's not so much that you're questioning their diagnosis, it's that you're asking them to be a little more specific. If they already know whether or not the patient's got left or right heart failure, and they do based on how they treat them medically and the drugs that they're on and that sort of thing, then why can't they document that, and then the reimbursement will be accurate? So downcoding basically means that you use a lot of unspecified codes, and so you're missing out on reimbursement, but you're also missing out on accurate reflection of the patients and their needs and their severity and all of that. So it goes on to say, undercoding is damaging to your practice from a compliance perspective, according to the National Correct Coding Initiative. And yes, we will dive into that in a few weeks when we get into CPT. And general correct coding policies. If there exists a HCPCS or CPT code for describing services performed, physicians must report that code instead of using a less comprehensive code along with other codes that describe the services not included in the less comprehensive code. So in other words, it is required to report services exactly to the level of service provided and as supported by medical necessity. Anything less is non-compliant. So whether you overcode or you undercode, both of those are considered non-compliant. They're on the edge of fraudulent and definitely not something we should be doing. The services you claim are reimbursed in lower rates, so you won't receive any explanation for lower reimbursement. To detect downcoding errors, you have to be familiar with the fee schedule and compare that to the amount mentioned on the EOB form. So going back to downcoding and looking at it from a diagnostic coding standpoint, we're looking at HCCs this week in your discussion. And as you complete your HCC discussion, think about how would it impact your HCCs if you are downcoding. If instead of saying whether it's left or right heart failure, whether it's acute on chronic exacerbation or just simply chronic or unknown, think about how that has an impact. If you're having to use unknown for the severity of the illness, unknown whether it's left-sided or right-sided, and those types of things, that's really going to hit you with HCCs, and it's also going to hit you with your reimbursement. And then, of course, we've already talked about how bad upcoding is, that you definitely don't want to go there. So some examples of downcoding. Diabetes is a prime example of an often undercoded condition, as some providers simply default to diabetes without complications. However, this diagnosis requires that the specific type and control method be fully documented. In the second example, if a unilateral partial mastectomy with axillary lymphadenectomy is performed, the proper CPT code would be 19302 rather than 19301 with the additional code of 38745. Okay, so the second one we'll get into when we go into CPT. But if there's a CPT code that encompasses the entire procedure, you need to use that. You should not be using a lesser code and then adding an additional code on. That's what they're talking about downcoding. We'll also, when we get into CPT, we'll be talking about bundling and unbundling. And the second example sort of is that way. But you're really looking to be specific, you're looking to be accurate, and you're looking to be complete. So think specific, accurate, and complete when you're coding. You want to be specific and use not otherwise specified or unspecified as few times as possible. You want to be accurate. You want to choose the correct code based on your documentation, and you want to be complete. You want to use the code that reflects all of what's going on with the patient if there is one, rather than using multiple codes to add up to that. So some tips to prevent downcoding. Thorough insurance verification. When you do that, you can understand the claim processing of each insurance company better and also all the codes they accept. And this will help you to make sure whether you are coding the claims correctly and providing all supporting documentation. You want to improve your documentation. As mentioned earlier, downcoding typically occurs from not providing sufficient details of the services performed or the diagnoses, either one, the details of the diagnoses. Office visit notes alone are often not sufficient enough to clearly define the complexity of a patient's medical history and the physician's medical decision making. And so it goes on here to talk about, according to the supplemental appendices for Medicare Fee-for-Service 2015 Improper Payment Report released by DHHS, Department of Health and Human Services, the established office visits top the list of 20 types of services with downcoding errors. You need to consider all the evidence while coding for established patient visits, including patients' past family and social histories, lab test results, x-ray reports, or other diagnostic services relevant to the service, and any orders for these services, referrals, and consultation reports. This information should be submitted along with a claim to substantiate the service level. So what they're saying here is that there are, and we'll get into this with CPT, but there are office visits that are downcoded. They are, the CPT code that's attached to them is less than what it should be, because if you go through the record and you consider all the information and what all went into the physician's medical decision making and what all was documented about the patient's history, when you look at past family and social histories and all of that, those would have justified a higher office visit CPT, or an E&M code is how they're known, an E&M, Evaluation and Management Code. It would have been justified, but because no one took the time to do that and to submit the additional information along with the bill at the point that they sent it in to substantiate that higher service level, that's an example of downcoding. Coding audits. Coding audits need to be conducted for both upcoding and downcoding. And then the audit findings need to be shared, not only with the coder, but with the providers, incorporating the auditor's recommendations and giving subsequent education to the providers and coders in your practice. This prevents you from submitting claims with downcoding errors. And then I like this last one. It's a good reminder for all of us. Do not trust your billing software blindly. Instead of trusting the codes that your medical billing software suggests, consider obtaining help from experienced and certified coders. You can use electronic billing to speed up the medical coding and submission process. However, you should always take advice from experts to ensure accuracy. Some additional information. This just goes through again the differences between upcoding and downcoding, and I'm going to read through this really quickly in case you need to hear this as well as see it. It's a good way to remember it, because the more times we see it, hear it, write it down, those types of things, the more it clicks and sticks in our memory. So upcoding means reporting a higher level service or procedure or a more complex diagnosis than is supported by medical necessity, medical facts, or the provider's documentation. For example, reporting a diagnosis of chronic bronchitis if the patient has acute bronchitis qualifies as upcoding, as would be the only way that would really qualify as upcoding is if you included both. If the patient just has acute bronchitis, that's all you code. If they just have chronic bronchitis, that's all you code. If they have both, you can code acute on chronic bronchitis. If they have just chronic bronchitis and you report acute bronchitis, that is upcoding. I think this is not quite as clear as I was hoping it would be. Moving on, as would be billing a level 5 E&M, Evaluation and Management Service, for a minor patient problem, or coding for excision of a 2.5 centimeter skin lesion when the lesion actually measured 1 centimeter. Because when we get into CPT, especially when you're talking about skin lesions, you'll see that there is size in there. And so you have to know the size of the lesion. Upcoding, whether intentional or not, is a serious compliance risk that will eventually, if it doesn't immediately, lead to payer audits, reimbursement takebacks, and charges of abusive or fraudulent billing, which can end up putting people in jail. It can end up with them stripped from the Medicare and Medicaid programs where they can't serve those patients. It can end up with lots of expensive financial penalties. So there's a lot to that. Downcoding is the opposite side of the upcoding coin. Typically, downcoding occurs because the provider fails to provide relevant documentation details to assign a service, procedure, or diagnosis to the optimal level of specificity. For example, diabetes is frequently undercoded. Many providers default to diabetes without complications, whereas correct coding requires that the provider document the type and method of control. Some providers may downcode as a defensive strategy to avoid denied claims, audits, etc. For example, many payers now examine the frequency distributions for E&M billing codes to identify outlier providers who bill a greater than average number of higher E&M services. Providers may purposely undercode in the mistaken belief that they must mirror these E&M bell curves to be compliant, and that is mistaken belief. Because if you've got the documentation to show that your patients genuinely are that sick, or that you did that much in that one visit, you absolutely should be claiming that. Sometimes those that are higher on the end of the E&M bell curve just have, they do better job documenting. They have more, I don't want to say aggressive, but they have more skilled coders who are looking at things and who are very consistent in their coding. And so if you get audited, you can defend that and they'll leave you alone. It's not a bad thing to get audited, as long as you have the documentation to justify it, to back it up. So again, you should avoid the strategy of downcoding. Regarding E&M services in particular, not every provider whose billing patterns fall outside the average is engaged in undercoding or overcoding. This is what I was just saying. A number of factors, including the provider's subspecialties, practice demographics, patient acuity statistics, administrative adjustments, and denied claims analysis, and even local public health data may legitimately affect the provider's distribution of E&M service levels. For instance, a provider may see a high percentage of patients with chronic health problems, which may skew his or her billing averages. So you just have to make sure you're not upcoding, you're not downcoding, and if you are, and no matter what, have your documentation and be able to justify what you do. And then here's the rest of it. Undercoding potentially harms patients, for instance, by documenting a diagnosis. It also preempts legitimate revenue, for instance, because the service billed reimburses less than the service actually performed, and it represents a compliance risk equal to that of overcoding. According to the National Correct Coding Initiative, NCCI, General Correct Coding Policies, Chapter 1, quote, physicians must avoid downcoding. If a HCPCS CPT code exists that describes the services performed, the physician must report this code rather than report a less comprehensive code with other codes describing the services not included in the less comprehensive code. So again, they give us the example of a physician performs a unilateral partial mastectomy with axillary lymphadenectomy, and it should be reported as CPT code 19302. An example of downcoding, which is bad, is reporting CPT code 19301 plus CPT code 38745. And that ends that quote. Periodic internal audits of your coding, billing, and documentation practices is one of the best ways to detect and eliminate upcoding and downcoding and many other compliance risks in addition. And I cannot emphasize that too much. I know it probably sounds like, yeah, but I realize nobody wants to be audited and nobody enjoys being audited. And having been on the other side of the fence, nobody enjoys doing audits. I mean, some people do. Some people genuinely enjoy it. Excuse me. For me, it was a necessary task. I did learn quite a bit from doing it, and I did enjoy aspects of it. I don't know that I'd want to spend 8 hours a day, 5 days a week doing coding audits. However, they are a good thing. They help you find your blind spots. They help you see what you need additional education or training in. They help you find things before they get out of hand. And so that's why you really need these periodic, regular, internal, and I would argue external audits to make sure that there's no bias, to make sure that there's no issue. So I'll go on with reading this. For example, you might self-audit 20 records per provider every 6 months to pinpoint inconsistencies between provider documentation and the codes reported. The goal of these internal audits is to ensure that documentation guidelines are met and that services, procedures, and diagnoses are supported at the level they are billed. Medical documentation should be unambiguous. It should be clear to the auditor as and not only to the documenting provider, and the entire note must be legible. So you need to be doing auditing, and you need to be doing it internally as well as getting somebody externally to periodically review as well. And you need to, we'll get into this a little bit more with NCCI when we study it, but the federal government puts out what they're looking at every year in their corporate compliance plan from the Office of the Inspector General. And so you can go out and see what it is that they're going to be auditing for each year or what areas that they think are prone for errors. And that's helpful to know. But bottom line is, it all comes back to the documentation. Is the documentation clear? Is it consistent? Is it accurate? Is it complete? Those are the things that have to happen. And is it legible? Hopefully in this day of EHRs, it is legible and there's very little that's handwritten. And then they go on to say, be sure to share audit results with providers as well as coding and billing staff and enact education and policies, including follow-up audits to correct errors going forward. Quarterly audits may be even more effective to correct bad habits, and you might also consider using an external auditor on occasion to verify your findings. Here's the bottom line. In every case, you should report and document diagnoses, services, and procedures to the optimal level demonstrated by provider documentation and medical necessity. Anything less is non-compliant. All right, so that's it for this PowerPoint. So now you are aware of upcoding and undercoding or downcoding, and you have that information. I hope you have a great week 8. If I don't see you or talk to you again before spring break, have a fabulous spring break. If you are behind, I wish you the best in catching up because it will take a lot of stress off your shoulders if you can get caught up and start out back after spring break on the 15th, feeling under control. So take care, and I will talk to you again soon. Bye.